Welcome everybody. In today's video, we are going to cover the lateral or Hardinge approach to the hip joint. So this is also known as the direct lateral approach and the transgluteal approach, because in this approach we go through the gluteus medius muscle. The common indications are hip arthroplasty for total and bipolar hemiarthroplasty and drainage of hip in a septic arthritis. This approach avoids the need for a trochanteric osteotomy and hence allows early mobilization. Also, when performing a total hip replacement through this approach, lower dislocation rates have been reported compared to a posterior approach. However, this approach has certain disadvantages, like the abductors are cut, so there may be a abductor weakness or abductor lurch which may develop post-surgery. The exposure is less compared to when a trochanteric osteotomy is performed, and thus this approach is not very suitable for revision surgeries. Now let us come to the technique of this approach. So the patient is placed in a supine or a lateral position. When the patient is placed in a supine position, the patient is taken to the edge of the table so that the ipsilateral buttock hangs. A straight incision may be used, which is centered over the greater trochanter, or a lazy J-shaped incision may be used. Following this, the fascia lata is divided in line with the incision, and the tensor fascia lata is retracted anteriorly and the gluteus maximus is retracted posteriorly. So here we can see that the tensor fascia lata has been retracted anteriorly and the gluteus maximus has been retracted posteriorly. When this is done, the insertion of the gluteus medius and the origin of the vastus lateralis comes into view. Following this, we have to split the gluteus medius. So how do we do this? So the fibers of the gluteus medius are incised obliquely along the anterior part of the greater trochanter, and we try to leave half of the posterior fibers intact. Following this, the incision is extended superiorly by splitting the fibers of gluteus medius at the junction of anterior 2/3 and posterior 1/3. So the fibers are split at the junction of anterior 2/3 and posterior 1/3. Now care has to be taken that this split should not extend more than 5 cm from the greater trochanter. Why? Because this puts the superior gluteal nerve and artery at risk. So if we stay within 5 cm, then this nerve is protected. Inferiorly, this incision is extended along the fibers of the vastus lateralis, which is split down to the bone along the anterolateral surface of the femur. So inferiorly, we split the vastus lateralis along the anterolateral surface of the femur, and now we get a flap. This flap with gluteus medius anterior 2/3 and a part of the vastus lateralis is retracted anteriorly to expose the gluteus minimus muscle over the joint capsule. So when we retract this flap, we get the gluteus minimus muscle. The next thing we have to do is to release the fibers of gluteus minimus from the anterior joint capsule. And once we release the fibers of gluteus minimus, the anterior joint capsule is exposed. Once the anterior joint capsule is exposed, we do a T-shaped capsulotomy and get an exposure of the joint. After this, the desired procedure can be performed and then the capsule is repaired. The next thing we have to know is what are the structures that are at risk during this approach. So the most important structure is the superior gluteal nerve. So why this is at risk? Because this runs between the gluteus medius and minimus around 5 centimeter above the greater trochanter. So we had discussed that the split in the gluteus medius should not extend more than 5 centimeter above. So what we can do is place a suture at the apex of the split so that this split does not inadvertently extend superiorly and put this nerve at risk. The second nerve at risk is the femoral nerve. So femoral nerve is the most lateral neurovascular structure in the thigh and it may be at risk during placement of retractors. So the method to prevent this is to place the retractors directly on the bone as close to the bone as possible. So friends, in this video, we discussed the Hardinge approach to the hip joint. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you would like to be covered in the future videos. Thank you.